sinonasal, paranasal sinuses, and the oral cavity. And the last session is going to be the neck, which includes the suprahyoid neck and the infrahyoid neck, in which larynx will be specially covered. This will be next week. Now, we know that neck anatomy over the years has been, in imaging, we use the concept of spaces. And there are spaces in suprahyoid neck and infrahyoid neck. I will introduce you, and I think most of them will be covered in more detail next time. But in suprahyoid neck, these are the 7 spaces. Out of these 7 spaces, some of the spaces continue in the infrahyoid neck. So carotid space, retropharyngeal space, perivertebral space, it is present in infrahyoid as well as suprahyoid neck. Today, we are going to cover a bit of masticator space as well as parotid space, in addition to the oral cavity and paranasal sinuses. So these are the 5 spaces of infrahyoid neck. Again, will be covered next time, but just wanted to highlight that these 3, carotid space, retropharyngeal space, and perivertebral space, also are in the suprahyoid neck. So they are in the suprahyoid neck as well as infrahyoid neck. So some of these spaces, they act as tubes. They go all the way through the neck, and many of them, they actually reach the skull base. And it is very important to remember this concept, because tumors as well as infections can transmit through them to the cranial cavity. Out of these, masticator space is one which we will cover today once again, and parotid space, we will revise it. You remember that the masticator space goes to the skull base and it touches the foramen ovale here. The parotid space, of course, this is the stylomastoid foramen through which the facial nerves comes out. The jugular foramen, it is in continuity with the carotid space. We have sort of covered this, but the space in more detail, we will see it next time. So the key concept in head and neck radiology is, what is the epicenter of the lesion? Which space is involved? Once you decide that, then you see what is the differential diagnosis. And on the basis of the radiological features and the clinical history, you can make a final diagnosis. So I've also told you that the current Chapman, which is the 7th edition, has been revised extensively, particularly the head and neck chapter. It's totally newly written. And this is the differential diagnosis in masticator space. So please remember, masticator space, we have to revise it today because it is next to the other spaces which are our area of interest, and that is why we are going to cover it today and not leave it for the next time. Whenever we do a space, and I again repeat that we are going to do them more elaborately next time. There are 3 things. First, the name, then the extension. What is the extension? And then the contents. So these 3 things should be known. Now, masticator space, it extends from inferior edge of the mandible to the superior attachment of temporalis muscle. So the temporalis muscle goes and it attaches to the skull, of course. So you can see that masticator space involves all of this region. The major contents include the muscle of mastication, the lateral pterygoid muscle, the medial pterygoid muscle, the masseter muscle, the temporalis muscle. And of course, there are some nerves. And as far as mandible is concerned, the ramus and the posterior body of mandible. So this is the mandible, and this is the body, and this is the ramus. So all of this will be included, and a few of the molars will be included in the masticator space. So this purple space for you is the masticator space, and you can see that this is the mandible. Surrounding them are the muscles of mastication, and all of this is included in the masticator space. Anterior to that is a space which is the space in your cheek. We call it the buccal space, otherwise it's not very important. You should just understand that this is the fat around the cheek. Posteriorly, there is the parotid gland. So this is the parotid space. So this is now in a craniocaudal dimension. If you see, this is the mandible. This is the purple space, which is the masticator space. You can see it goes all the way here and attaches with the temporalis muscle here. So here it is abutting the base of skull. And this is what we call the mandibular division of the trigeminal nerve, which is the V3, which passes through the foramen ovale. And the same concept that the masticator space goes and touches the base of skull. This is the foramen ovale, this is the foramen spinosum. Once again, this tells you the V3, which passes through the foramen ovale. So on CT scan, and please remember, these kinds of cases are extremely important for the exam. Because of time factor, I might not be able to show you DICOM images today, but I've got a few in my collection which as a practice for your 2B exam, I'll show you. So now look at this, and this should be your protocol. That when you are looking at a CT scan of the brain, you should understand that after looking at the brain, you have to look at the base of skull and anything else in the head and neck. So this is the masticator space. Simple. It's easy to forget. So this is the nasopharyngeal masticator space. And actually, this is the Pterygopalatine fossa, which we are going to cover. So people tend to forget that. So this is the temporal bone. Anterior to that is the masticator space. So, and which will be visible, maybe the first space, soft tissues of the neck, which will be visible on a CT head, will be this part. And it is posterior to the maxillary sinus. So next, I'm going down now, and you can see that this is the condyle of the mandible. And you can see that this is the masticator space. This is the medial and the lateral pterygoid plates. And more inferiorly, now the ramus of the mandible is evident. And you can see that this is the masticator space. Posterior to that will be the parotid space. And now we are going further inferiorly. And we can see that now the body of the mandible is coming into view and the alveolar ridge is coming into view. So if there is a tumor in the masticator space, for example, or infection or whatever, it will sort of indent the parapharyngeal space, which is here. And the displacement of the fat of the parapharyngeal space is taken as a landmark. And we are going to learn this skill next time. So this is the differential diagnosis. Once you place anything in the masticator space, Of course, there will be many things which you can see here, including infection, including bony lesions, including incidentalomas and motor denervation, tumors, etc., etc. So, because of radiological features, etc., you can give a good differential, and many times you can give a single diagnosis. Now, this is a chondrosarcoma of the masticator space. So, the first thing is ask yourself which space is involved. It's a good idea to compare it from the right side when you're not experienced on the other side. So, you can see that this is the mandible, and you can see that these are the muscles of mastication. Here, there is a mass which is replacing the muscles. The muscles are not visible. And then it is causing indentation on the maxillary sinus like this. And key point is parapharyngeal space. So parapharyngeal space is one of the key spaces to sort of reach a conclusion of what is happening, which space is the mass or the tumor or whatever. So parapharyngeal space has got fat, which is high in signal intensity on T1 as well as T2 weighted sequence. This is normal. So you can see that the displacement of the fat will tell you which space the mass is. And on this side, there is anterior, something is displacing it posteriorly, telling you that this is in the masticator space. So this is how you use your differential diagnosis skills. This is just a diagram to show that a tumor in the masticator space can go into the intracranial cavity through the V3. We call it perineural spread of tumor. And of course, it will pass through the foramen ovale. This is a case in which there is enhancement and enlargement. I've shown you similar case when we were doing temporal bone, and maybe I'll show you later today once again. So let's go through in a DICOM format. Now, candidate 1, can you see my DICOM viewer?
Yes, I can.
Okay, so now we are going to sort of revise our masticator space. So just concentrate on masticator space and nothing else. Now, if you see here, and I'm going to concentrate on the left side here. So if you see here that this is the mandible, and as we are going superiorly, you can see that this was the anterior portion of body of mandible, and as we are coming to the junction of body with ramus, you can see the alveolar ridge here, inferior alveolar ridge. You can see the teeth here. And on the other hand, you can see this muscle. So this is the masseter muscle, and this is the temporalis muscle. So now means that this is the masticator space. Look posterior to that, and this is the parotid gland. So this is the parotid space. So we are going now superiorly. And as we go superiorly, we can see that there are other muscles, the pterygoids, etc., which have appeared from here. If you look very carefully, you might see the pterygoid plates where I'm pointing out. Having said that, this will be better seen on a CT scan for the simple reason that they are bone. However, you can see that these are the muscles, the medial and the lateral pterygoid, temporalis, masseter. So all of this is the masticator space. So let's go down once again and come back. Now, this is it. The mandible is the landmark. Mandible is continuing. And here comes the condyle. So this is the mandibular condyle, and the space comes superiorly. Now look here, the temporal bone is here, the brain is here. And this is what I was showing you on a CT scan, that when you are doing a brain image, please remember that the masticator space will be the first space, first soft tissue visible anteriorly. And if there is something there, don't miss it. Now, if I go superiorly, you know, there is a muscle here. So this muscle has to be the temporalis muscle. So this was the masticator space. Here, we can also cover the parotid space. Now, this is the mandibular condyle. Posterior to that, this thing is the parotid gland. And in the parotid gland, there is a vein here, which is the retromandibular vein. And parotid gland has got two portions. One is this superficial portion. So this is the skin. So the portion which is superficially placed is the superficial portion of the parotid gland. This one is the deep portion. Deep portion is clinically not evident, which makes common sense because a clinician will not see it. So, and similarly, when we report tumors of the parotid gland, we have to tell the clinicians if the deep lobe is involved or not, because the surgical approach or the planning will be different. So within the parotid gland, the facial nerve is there. You might not see it, but you can infer it. Retromandibular vein is there. But as we go superiorly, so this is the parotid gland, and as we go superiorly, now this is the signal void of the mastoid hair cells. And then this is the condyle, and then we lose it. We are into the brain. So you can imagine that somewhere here, we lose the facial nerve into the signal void of the mastoid hair cells. And we have done this anatomy on temporal bone in the first session. And posterior to that, of course, this is the external auditory canal, etc. So in conclusion, around the mandible, here is the masticator space, and posteriorly is the parotid space. Right. Now, we go back to where we were. Candidate 1. So can you see my PowerPoint?
Yes, it's PowerPoint now.
Right. So candidate 1, this is your first case. Over to you.
Okay, there are slices of axial CT head. I can see that there is a right anterior frontal, right frontal collection, which is hypodense with the surrounding hyperdensity, and it is in keeping with a subdural collection. I can see on bone window that there is right frontal maxillary sinus disease. So the findings are in keeping with subdural empyema due to frontal sinusitis.
Okay, I think you used the word, did you initially use the word maxillary, isn't it? This is
sorry, frontal, right frontal sinus, yes.
Okay. So in this case, and you use the word subdural, and why isn't it extradural or epidural?
It is extradural because I can see that there is kind of buckling of the sulci, and I never thought of that. I would just usually just say that. Yeah, the anatomic description, it would be because it's outside of the parenchyma, it's extraaxial.
Okay, that's fine. Now, this is a classical case for the exam on a brain CT. So these are brain sequences. The patient presented with headache and that kind of a thing. So what we see is that in your exam, you will pick this up. There is an enhancing lesion here. This is an epidural abscess. And once you see this, you will ask for a bone window. And on a bone window, in this particular case, you can see that there are signs of sinusitis, opacification of the right frontal sinus. There might be some bone dehiscence. In this particular case, there was no dehiscence, but it can, even then, there can be an epidural abscess. So this is a classical case which is for the exam. Now, candidate one, over to you.
Okay, so in this case, there is complete opacification. There is opacification of the right maxillary sinus, and looking, there is a small. I can still see a small area of air. So looking at this image, there is air and also opacification. So this one actually could be due to mucosal retention cyst, because if it was just a fluid inside of the maxillary sinus, I would expect to see kind of a air fluid level.
Excellent.
And
what would you like to do?
Yeah. So I would like, I will inform the clinical team, and this patient needs, will take more clinical history from clinical team and needs to proceed with CT.
Here you are, CT.
Okay. On CT on bone window, I can see that, yes, there is area of opacification with irregular border involving the right maxillary sinus, confirming the findings of the skull X-ray. I would like to have a look at the soft tissue window because I'm thinking that this could be actually an abscess, and in the anterior aspect of the right maxillary
tissue window, there was no abscess. Over to you.
There was no abscess. Okay. The other possibility is actually, so if there was no abscess, it would be in keeping with bony proliferation. So the appearance is like ground glass appearance and heterogeneous. So in a, for example, young patient, we think of fibrous dysplasia is the top differential. And so it would be like a...
Which bone is involved?
The maxillary, it's the maxillary sinus, so it's the zygoma. Frontal, I'm just trying to the zygoma, the zygomatic frontal suture is involved here. So it's gonna be...
That's fine, yeah. Well done, well done. Now, this is a case of fibrous dysplasia. Now, fibrous dysplasia, if you see here on this plain X-ray, what has happened is that there is a what we call opacified, opaque right maxillary sinus. But if you look carefully, then it was very well picked up that part of the sinus is still visible. So whatever it is not causing complete obliteration of the sinus. Then on a CT scan, it is clear that actually this is a bony lesion, and this bony lesion is involving the maxillary bone as well as the zygomatic bone. The configuration is ground glass, classical ground glass. So this is fibrous dysplasia. Now, please remember that this is the differential diagnosis in your book, Bony Lesions of Mandible Maxilla Solid. And one of them is fibrous dysplasia. So So if you see here, bony lesions of mandible, solid, and then lytic and sclerotic, calcified, ossified, unrelated to teeth is the subheading. Here, unrelated to teeth is the subheading, ground glass, mixed or variable. Fibrous dysplasia is extremely important for your exam, and you should have clear-cut concepts about fibrous dysplasia. The summary is written here, so you can revise it from here. But let me tell you that people think that fibrous dysplasia is only ground glass. Do not think like that. Fibrous dysplasia can be ground glass, but it can also be lytic, and it can be mixed, what we call page-to-eye. So basically, when it is lytic, it is more active, and it will show uptake on bone scan and PET scan. When basic pathology is that it is, these are cysts in the bone, and then there is variable degree of ossification, and at a particular time, that ossification might give you a ground glass matrix. Now, the fibrous dysplasia of the face or the face and calvarium can be seen in 25% of monoostotic disease and more than 50% of polyostotic. Maxilla is the most common. And please remember that we have covered it previously in the last session, that to differentiate it with Paget's disease, one discriminator is age. Fibrous dysplasia will be young age group. Second thing is facial bones are more commonly involved in fibrous dysplasia and in Paget's disease, it's the calvarium. And once again, I repeat that please remember that depending if it is active disease, it will show uptake on bone scan and PET scan. And they have shown PET scan as well as bone scan in the exam in other parts of the body. So that doesn't change it. So this is fibrous dysplasia. Okay, now candidate 1. Let me describe this for you. This is an MRI, and this MRI was a brain MRI. And expect that to happen. That the finding is in the paranasal sinuses, but this is a classical brain MR. A flare sequence, coronal T2, axial T2 and axial T2. Now, in the right sinus, right paranasal sinus, we can see this signal which is replacing the sinus completely. And then we can see something here within the nasal cavity. If you see this and see here, you see this configuration? So something is going from here to here. Can you describe it and give us your conclusion?
Sure. So this is, there is a complete, the right maxillary sinus is completely opacified, and it shows a high T2 signal intensity.
Excuse me, can I stop you there? Opacified is a terminology for CT scan, right? There it becomes fake. So here it is. Yeah.
So it's a high signal intensity involving the whole of the right maxillary sinus, and it is invading into the right ethmoid sinus with evidence of cortical breach. And it looks like the epicenter of the lesion is within the maxillary sinus, and from there is extended into the ethmoid sinus. So one of the differentials here, I'm thinking, could this be due to inverted papilloma? But I would like to see if there is any CT for this patient. But actually, inverted papilloma is usually coming from the cerebriform. It has a cerebriform pattern, and it comes from ethmoid coming down. So one thing would be helpful to see if there is any hyperostosis focally. And the other thing, could that be just polyp?
Can I stop you there? can I stop you there? Look at the signal. It is completely fluid signal, right? So, so now you don't speak. I'm just going to tell you a few points, and then we will go into a teaching mode of anatomy. Now, the first thing is the signal. It is high signal, just like fluid on a T2 weighted sequence. Usually, a solid tumor will not behave like that. Now, but that's a peripheral discussion. The main discussion is anatomy. Now, if you see here, the lesion is in the maxillary sinus. Here, it does not go into the ethmoid sinus. It is sitting in the nasal cavity. So this is the inferior turbinate, this is the inferior turbinate, and the lesion has gone here. So through which structure will it go here? It must have caused expansion of something, and that is why it has gone here. So we will go now into a teaching mode regarding anatomy, and we will come back to this case. So candidate 1, this, I will take 15-20 minutes to go through it. You please stay with us, but I'm not, most probably I'm not going to ask you questions. Are you with me?
Sure, yeah.
Now, can you see my PowerPoint nasal cavity and paranasal sinuses?
Yes, I can see that, yeah.
Okay. Now, here, if you see here, there are 6 sinuses, paranasal sinuses, and they are named on the bones from which they arise. So 2 maxillary, 2 ethmoid, 2 frontal, and 2 sphenoid sinuses posteriorly placed. In the center is the nasal cavity. Now, if you see this nasal cavity, there is a septum here, and there are bones projecting into it. Please remember the physiology. Normal physiology is that the sinus, they produce, secretions, mucociliary, and there is a drainage pathway. And all of these sinuses have got a drainage into the nasal cavity. And from there, it goes into the nasopharynx. And we just swallow it. So if the drainage pathway is blocked, then you can get sinusitis. Of course, there is other etiology also, but the main thing here is to learn the anatomy of the drainage pathway. So if you see here, just concentrate on this maxilla. So this is the maxilla, and this is the alveolar ridge of the maxilla. This is the nasal cavity, and you can see that there is a bony septum here. And these are the bones which are visible within the nasal cavity. This is the middle turbinate and the inferior turbinate. So if you see the midline bony anatomy, the septum, which was this bony septum, can be seen here. And 3 bones actually contribute in making this bony component of the nasal septum. Include the ethmoid bone. This is the perpendicular plate of the ethmoid. Then there is the vomer, and then there is the palatine bone. You don't have to worry about these names. You should only know that the nasal septum is partly bony, and this is that part. Here, I will show you in a diagram shortly. There is a cartilaginous part also. So we take it further. Now, if you see here, this is the nose, this is the nasal bone, and there are cartilage here. Of course, this is our nose. Now, if we look inside the nose with a speculum like this, you can see there is a bone projecting inside. This is the inferior turbinate. and then this is the middle turbinate, also known as concha. So I'll use the word turbinate. Now, key point to remember here is vocabulary wise that this is the middle turbinate, this is the inferior. You can see that inferior is larger. The air space which is lateral to the middle turbinate is the middle meatus. This is an extremely important word which you have to remember, middle meatus. Most of the drainage actually happens into this. And here, lateral to the inferior turbinate is the lateral meatus. Now, this diagram has been made by one of our team members, Syed Sabi, who is also creator of our logo actually. When we started this 2 years ago, now he's doing his training in radiology in London. So if you see here, concentrate on this. The main bone here to learn from is the ethmoid bone. Ethmoid bone is extremely, complex bone. And if you see here, this is how the ethmoid bone is. There is a horizontal plate, which is this one. This is the horizontal plate. If I go here, do you see this? This is the horizontal plate, also known as the cribriform plate. So this makes the anterior cranial fossa portion of it. And you remember the olfactory nerves, they pass through it. Now, so this portion is the perpendicular, the horizontal portion of the cribriform plate. This thing is the crista galli, which is this thing. Just a landmark because the dura, it attaches here, and I've shown you on a brain MR, it is beautifully seen, particularly on a sagittal sequence, because there is fat around it. Now, from here is a perpendicular plate of the ethmoid. So this is the perpendicular plate, which is seen here. Now, there is complex structure here and complex structure here. This is the lateral mass, also known as labyrinth, whatever you want to call it. So this is the lateral mass. The ethmoid sinus is sitting within it. So this is the ethmoid sinus. And this is the ethmoid sinus. It is aerated. And key point to remember is that the orbits are right and left. So the bone between the ethmoid sinus and the orbit, this bit where I'm pointing out, is known as lamina papricia. This is a very thin bone and an exam bone because infections of the ethmoid sinus can go into the orbits. And this is a very important concept, which we will come back to this. So now, if you see these names, once again, so this is the cribriform plate. This is the lateral mass. This bone is the lamina papricia, which is touching the orbit. This is the perpendicular plate. And then inferiorly, we can see the vomer, which forms the bony nasal septum. Now, to add to this complexity, there are bones which are projecting from the ethmoid, and these are, one is what we call the superior turbinate, also known as superior concha, but I'm using the word turbinate. This is the middle turbinate, and we are very much interested in the middle turbinate. And there is another bone which is inferior turbinate, but inferior turbinate is not a part of the ethmoid bone. Anatomically speaking, it is actually a different bone. Now, this thing here is a structure which I will come back to shortly. This is the uncinate process. We'll come back to this. Now, this airway here is our area of interest. This is the middle meatus. So this is the maxillary sinus. You can see the maxillary sinus is opening here into the middle meatus. So this is the schematic diagram of a paranasal sinus. Before we take it further, one concept you have to remember is that the ethmoid air cells, we divide them, there are about 3 to 18 air cells. Anatomically speaking, something which is anterior, we call them anterior ethmoid air cells, middle ethmoid air cells, and posterior. And these ones are sphenoid. These are the sphenoid sinus. So this concept is important to remember because the drainage pathway is different. Now, you have to concentrate on these diagrams. And this is the midline sagittal diagram. It passes through the nasal septum. And you can see that this nasal septum is then in continuity with the nasopharynx. Inferior to that is the palate. Now, this is the hard palate where the bone is, and then there is a soft palate. So whatever is passing, the secretions of the paranasal sinuses ultimately pass into the nasopharynx, and from there the oropharynx, and we just swallow them. We don't even realize it. Now, this is the bony part. So the mucosa has been removed, and now you can see that the bony nasal septum, the midline, perpendicular plate of the ethmoid, the vomer, and the palatine bone. Here anteriorly is a septal cartilage. Please remember that this septal cartilage is immobile. More anteriorly, the septal cartilage is mobile. And it becomes a very important concept for you to remember because an exam case is where there will be destruction of the septa. And you have to understand that posteriorly, the septa is bony, more anteriorly, it is cartilaginous. So don't overcall it. Now, key thing is the lateral wall of the nasal cavity. So right now, we just learned the nasal septum. Now we are looking at the lateral wall. When we look at the lateral wall, the turbinates, they hide everything. So this is the superior turbinate, which is part of the ethmoid bone. This is the middle turbinate, which is part of the ethmoid bone. This is the inferior turbinate, which is a separate bone anatomically speaking per se. So lateral, hidden from our view here, is the superior meatus. Here, hidden from our view here, will be the middle meatus, laterally speaking, and the inferior meatus here. So what we do is, without mucosa, so this is the superior turbinate, middle turbinate, and the inferior turbinate. Now in this diagram, what has happened is that we have removed the turbinates. And now we are looking at the lateral wall of the nasal bone. And this lateral wall is the key thing to learn. Because on the lateral wall are key landmarks. One of them is this semilunar groove, which is known as hiatus semilunaris. This is a groove. And in this are various openings. Now, the first opening is for the frontal sinus. From the frontal sinus, the secretions go through the nasofrontal duct and ultimately they go into the hiatus semilunaris. And hiatus semilunaris opens into the middle meatus. And then the secretions go like this. Now, other than the frontal sinus, the anterior ethmoid sinus also drain into the hiatus semilunaris. And the maxillary sinus, so this is the opening of the maxillary sinus. It also opens here. Now, there is a very important landmark here, and this is an exam landmark because it is very well seen on a coronal CT scan, and there is importance to it. And it can be asked as an anatomy question in your exam. Here is this, this convexity. This is known as ethmoid bulla. What is ethmoid bulla? Basically, ethmoid bulla is the medial inferior wall of middle ethmoid air cells, and this has got a bulbous type of appearance, convex inferiorly and medially. It projects into the middle meatus. So please remember, on a coronal CT scan, it can be seen beautifully, and I'll show you. Now, through the ethmoid bulla, the middle ethmoid air cells, they also drain into the hiatus semillunaris. So a recap, in the hiatus semillunaris, the frontal sinus, the anterior ethmoidal sinus, the middle ethmoidal sinus, as well as the maxillary sinus, all of them, they drain into that, ultimately into the middle meatus, and then drain into the nasopharynx. Now, the posterior ethmoid sinus actually drains into the superior meatus, which is not very well seen on radiology. Now, on the other hand, remember that two sphenoid sinuses are sitting posteriorly. These sphenoid sinuses, they have got a ostium where the probe is here, and they ultimately open into the, we call it the sphenoethmoid recess. So the superior meatus also drains into the sphenoethmoid recess. The sphenoid sinus, it drains into the sphenoethmoid recess, and from there into the nasopharynx. Now, one point is that in the inferior meatus, there is opening of the nasolacrimal duct. And you remember last time I showed you a dacrocystocele of the nasolacrimal duct, and that opens into the inferior meatus. And that is why when we cry, you know, the tears, they come out through the nasal cavity like this. So this is the same recap. This bony portion, this is the lateral wall of the nasal cavity, and the openings are anterior ethmoid air cells, then the frontal sinus, then the maxillary ostium, and of course this is ethmoid bulla, and here the middle ethmoid air cells are also drained. So this is same thing here repeated, and I want to repeat here is that the posterior ethmoid air cells, they drain into this thing. This is known as sphenoethmoid recess, and the sphenoid sinus also drains into this and into the nasopharynx. So this diagram is exam diagram because this is what is asked anatomy question wise. If I want to ask you something in the exam, part 1 exam, anatomy exam, I'll ask you through this sequence. And this is the coronal, and as an ENT surgeon, they want us to describe this because they want to know what is happening. There is a surgical procedure, we call it FESS, F-E-S-S in capital, functional endoscopic sinus surgery. Basic concept is that they want us to tell them if there is obliteration of the osteomeatal complex, also known as osteomeatal unit. So I will tell you what is an osteomeatal unit or osteomeatal complex. The ENT surgeons want us to tell them the anatomy there, and that is why they will ask you in the exam. And if they want to do surgery, what they do is they actually remove this uncinate process so that the drainage pathway becomes more spacious. Now, the portions of osteomeatal complex, if you see, this is the maxillary sinus. This is what we call the maxillary ostium. From here till here is the infundibulum. You see this maxillary infundibulum. It opens into the hiatus semillunaris. On a coronal sequence, hiatus semillunaris, you have to stretch your imagination to be able to see it. You don't see it on a coronal sequence, but it's common sense that this is the hiatus semillunaris. And this air space here is the middle meatus. Now, this is the middle turbinate, and this thing here, you see this ethmoid bulla, and this is the ethmoid air cells, and you can see that how it is producing this convexity laterally placed, and there is an ostium here also. So the middle ethmoid air cells will be at this level, and they will drain into the middle meatus. And this is the uncinate process. And remember that this is what they remove when they do surgery, uncinectomy, they call it. So this is a CT scan. And if you see here, this is the maxillary sinus. This, where I'm pointing out, is the maxillary ostium. From here to here will be the infundibulum. Then if this is the middle turbinate, so this airway is the middle meatus. And this thing is the ethmoid bulla. So the osteometal complex, the key parts of osteometal complex include the maxillary ostium and infundibulum. It includes the ethmoid bulla, the middle meatus. So this is the middle meatus, the airway, and the middle turbinate, and the uncinate process. So this is the osteometal complex. Now, so I think we take a 5-minute break here. When we come back, I will go through a DICOM of a paranasal sinus, and which will consolidate this anatomy. So 5-minute break now. Candidate 1, are you with us?
Yes, Dr. Khan, I'm here.
Can you see my DICOM viewer?
Yes, it is the DICOM viewer.
Okay. So now we are going to go through anatomy CT of a paranasal sinus, and the best initial plane to evaluate the CT scan of the paranasal sinus is a coronal. So coronal is the best plane. First of all, let's have a global view of the facial bones, and then we will come back to the paranasal sinus. So this is the alveolar ridge of the maxilla, and we can see that, so this is the right maxillary sinus, left maxillary sinus. Of course, it has to be in the maxillary bone. This is the maxillary bone. Now, lateral to that, this is the zygomatic bone. So the zygomatic bone is here, and you can see that this is the orbit. So here is the frontal bone, and there is a suture here, the frontozygomatic suture. Frontozygomatic suture is an exam suture, and they will show you cases of trauma. And there is a concept of Lee-Fort injuries, where this is the lateral wall of the orbit. This is the medial wall of the orbit. So I'll show you a few cases later on, and you have to tell the examiner if the fracture is going through it or the lateral wall is also fractured or not. So this is the frontal bone, and within the frontal bone is the frontal sinus. And now, if I go more posteriorly, then here, this is orbit. So medial to the orbit is the ethmoid sinus. So remember, the orbit is still in view, and this is the ethmoid sinus. Orbit, you are going towards the orbital apex, and then you go into the sphenoid sinus. So this is the sphenoid sinus, and you remember your foramen rotundum and the Vidian canal. This is the Vidian canal, and the key point was that Vidian canal is inferior to the sphenoid sinus, and foramen rotundum is lateral to the sphenoid sinus. More posteriorly, we are going into the pituitary fossa, and of course, then the cranial cavity. So with this overview, and another point which is important as far as overview is concerned, that this thing is the pterygoid process of the sphenoid, and we have got a medial and a lateral pterygoid, medial and a lateral pterygoid. And this becomes a exam anatomy, because they will show you cases of trauma. If the pterygoids are fractured, that will fit in with the criteria for Lee-Fort injury. So remember, Lee-Fort injury is Lee-Fort 1, 2, and 3, and I'll show you cases. And in each of them, one of the prerequisite is that the pterygoid has to be fractured, either unilateral or bilateral. So these are the pterygoid plates of the sphenoid. Now, forget about the facial bones, and let's concentrate on the paranasal sinuses. So we have gone anteriorly, and we are coming from outside the body. So this has to be the nasal bone. And you can see that this is the nasal septum. Now, here is the alveolar ridge of the maxilla. So this is the septum. Part of the septum, as we are going posteriorly, you can see that whole of the septum becomes bony. On the other hand, as I come anteriorly, you can see that the septum is there, but it hasn't got a bone. So this is cartilage. So this is one point to remember. Now let's, if we stop here, this is what we learned as far as osteometrial complex was concerned. Now, if you see carefully, this is the nasal septum, and here, this is the middle turbinate, this is the inferior turbinate. So this is the maxillary sinus, and you can see the ostium here. From here to here is the infundibulum. And this lucency here is the middle meatus. On the other hand, you can see orbit here. So this thing, this convex structure here is the ethmoid bulla. And this thing is the uncinate process. This is the uncinate process. This, of course, is the inferior meatus. So as I'm coming anteriorly once again. This time, our aim is to see the frontal sinus. So this is the frontal sinus. And you can see that there is a groove here. And actually, you might be able to see in some cases very well, but somewhere here, and actually you can see it here, where I am pointing out. Do you see this lucency, which is continuously going like this? So this is the nasofrontal duct. And actually it's a recess type of a thing. And from here, the pathway again is into the middle meatus. And you can see it going like this. You see this thing? It is going like this. So, so this was the frontal sinus. Now we will continue posteriorly. Ethmoid sinus is still in view. You can see the orbit there, and then the orbit is finishing, and means you have gone into the sphenoid sinus. So let's sort of marry it with an axial sequence just for orientation. So now I am at the level of orbit, and this is the medial rectus muscle where I'm pointing out. And now you can see how I've gone anteriorly, frontal sinus, and now the ethmoid sinus. So these have to be the anterior ethmoid sinus. Now we are at the middle ethmoid sinus, and key thing is that this is the ethmoid bulla. You can see we are at the middle. We are going posteriorly, and now if you look carefully, we are still in the ethmoid sinus. This is the sphenoid sinus. This is the sphenoid sinus, and now we have gone into the sphenoid. If you look carefully on this axial, actually you can see, do you see this ostium where I'm pointing out? So this is the drainage pathway of the sphenoid into the sphenoethmoid recess. And generally speaking, if we see it on a sagittal, if we go here and try to orient it, so actually you can see it very well on, you see this thing? Do you see this ostium here, which correlates with this thing? So this is the ostium of the sphenoid sinus. And so from here, the secretions will come here. We are at the midline, but then if we go slightly medially, we can see it will go into the nasopharynx. So once again, on a sagittal, you can see the frontal sinuses here. You can see the, let me marry it with a coronal for orientation. So this is here. Now this is the crista galli. So here you are. This is the crista galli. And you can see this is the sphenoid sinus, the pituitary gland, etc. So whenever you see a CT scan of a paranasal sinuses, you have to describe the nasal septum. Is it deviated or not? You have to describe if the, sometimes there are normal variant where there is aeration of the middle turbinate, maybe slightly you can see it here. We call it concha bullosa. You have to mention it as a variant. At times it can cause a bit of obstruction also. You can then you have to describe the osteometal complex. And, this is the osteometal complex. Is it clear or not? And then you have to describe all the sinuses. Are they clear or not? And if there is obstruction, then you have to tell where the obstruction is. Then you look at all the bones and see if there is any bony destruction, etc. Finally, all paranasal sinuses CT, please remember, are basically in bone window, right? So you have to ask your radiographers to send a normal soft tissue window also on PACS, and you have to evaluate that also. Otherwise, you are going to miss things. So let's, from here, go to a few Viva questions. So if you see here what is happening, let me go through it. What is happening? This is an antroconal polyp. So polyp, basically there is mucosal thickening, and then this mucosal, because of hypertrophy, what happens is it will pass through the maxillary ostium, and it will sort of enlarge the maxillary ostium. So you can see it has caused expansion of the ostium, and part of it is projecting into the nasal cavity. Look at the signal intensity. It is high on T2 weighted sequence. It is fluid, should I say, in T2 weighted sequence. So this is a antroconal polyp. Now, a few things that role of contrast in sinus diseases is that when there is, on a CT scan, when you see opacification of the sinus, on an MR, it might be due to mucosal thickening, or what we call polypoidal mucosal thickening, or it might be because of two things. One is mucosal thickening, and second thing is fluid. Basically, what has happened is that the ostium is blocked, so there is fluid also. When you give contrast to this patient, sometimes what happens is that the mucosa is compressed and you might not see enhancement. Sometimes you will see enhancement. So this is the mucosa which is enhancing. Central portion is the fluid. Key point to remember, exam point to remember is that look at the enhancement pattern. Enhancement is smooth and thin. It is not nodular, because nodular enhancement means trouble, means there is a tumor sitting there. So this point you have to remember. Now, candidate 1. This is your last case, and then we will go to candidate 2. Now, are you with me, candidate 1?
Yes, I'm here, Dr. Khan.
Okay, so if you see here, this is a stir sagittal sequence. In head and neck, we do stirs. This is a T1 fat saturated post contrast, T1 fat saturated axial post contrast. The classical protocols which we use in head and neck, we use stir because stir by definition has got fat saturation. We will do T1 without contrast. T1 without contrast is beautiful in head and neck because of fat. We see anatomy very well. And then we do fat saturated T1 followed by post-contrast fat saturated T1. We can also do, or we do T2s also, particularly sagittal T2 to look at the spine, etc. So having said that, let me ask you leading questions on this because of the time factor. If you see here, there is a lot of fluid in the maxillary sinus, right and left, similarly in the ethmoid sinus. When we gave contrast, if you see this is the maxillary sinus, there is enhancement, there is enhancement, there is enhancement, there is enhancement. What do you think is happening? Over to you.
Okay, both maxillary sinuses, they show that there is a peripheral enhancement, so it could be in keeping with an inflammatory process or infective like sinusitis. But I can also see that within the ethmoid sinus, more on the right side, there is a heterogeneous signal intensity, which is not like only fluid signal. So I think it's most likely sinusitis in both maxillary sinus, but I think there is a lesion as well within the ethmoid sinus.
Is this the ethmoid sinus?
This is actually the nasal. This is the nasal nasopharynx. This is, I thought it's a
nasal cavity.
Nasal cavity, yeah, okay.
Okay.
So the soft tissue in the nasal cavity, I'm not sure. It could be a lesion there.
Yeah, I'll take over. So if you see, this is a classical exam case. What is happening is that there is a mass in the nasal cavity. First of all, on T2 weighted sequence, the signal intensity is not fluid. I have not given you a pre-contrast, but having said that, it enhances. So this was a nasal carcinoma actually, and it is causing complete obliteration. It's a large lesion of the nasal cavity. Of course, you don't see the what we call the middle meatus, etc. You can imagine that there is secondary obstruction. So this is a mass. Okay, candidate 1, thank you very much. Candidate 2, are you with us?
Yes.
Okay. Now, one point I want to make is that sometime in the maxillary sinus, as a normal variant, there can be septations, like this case here. So I just wanted to show you a normal variant where septations can be there. Now, candidate 2, because of time factor, I'm going to describe some of the findings and then hand the case over to you. Now, this is a coronal CT scan, and then this is an axial CT scan. Now, there is opacification of the left mastoid air cells, and there is a correction the left maxillary sinus and maxillary sinus. What is your observation? Over to you. I think you are unable to. What happened? Candidate 2.
Sir, I think I'm not a co-host, hence I'm getting. Can you make me a co-host?
Okay, I will. Here you are.
Thank you, sir. So this is an axial and coronal reformatted CT of the paranasal sinuses. There, in a patient with the left cheek swelling and pain, I see that there is a soft tissue attenuating opacification in the left maxillary sinus, extending through the antrum into the part of the ethmoid in the nasal cavity. There is aggressive appearance in the form of destruction of the
of the lateral wall, and there is a destruction here. Now, I have given you an OPG here. This OPG per se is an exam case, but we will tackle the OPG separately. First of all, I have given you post-contrast. So actually, this is osteomyelitis. So Now, if you see post-contrast, we can see that there is an abscess formation here. And the bony anatomy is not very well seen. If you see, there is an abscess formation here. Now, on this OPG, what is the key? I have intentionally not given you more sequences on CT and this. I have given you this OPG. If you concentrate on this part of the OPG and then tell me what is the etiology, what has happened, over to you.
There is a lucent area in the left inferior aspect of the around the upper lateral maxilla. There's a soft tissue opacification of the left maxillary sinus.
So look at the teeth here.
There is a lucency around that tooth, the first molar. So it could be an extension from a periapical abscess to the sinus.
So
it's an infection which has spread.
So here the learning point is, the exam point is that look at this tooth here and look at this tooth. Now from here to here is the crown, and this is all eaten up. There is no crown. And this is the root. And there is a bit of lucency even here, what we call a radicular cyst, even here. So there is infection of dental origin. So key point to remember is that you have to then see on this CT scan, actually this was visible. I have not intentionally given it to you. So this was a case of osteomyelitis. So this is paranasal with bone destruction, paranasal sinus lesion with bone destruction. Now, in this case, the patient has presented. This is a child, 15 years old, fever, upper respiratory tract infection, eye pain, blurred vision on right side. Now, look at the ethmoid sinus. Look at the adjacent orbit on this slice and this slice particularly, and tell me what is your diagnosis. Over to you.
Are coronal reformats showing fever with URTI, eye pain and blurred vision. There is opacification of the right ethmoid sinuses with adjacent spread to the medial aspect of the orbit. There is no aggressive appearance, there is no bony destruction, so this could be indolent sinusitis.
With this kind of clinical, what will you be worried about? What will you do next?
I would like to correlate with the inflammatory markers. As also, I would like to do a CT, a post-contrast study.
I've given you post-contrast MRI scan here. This is a T1 weighted fat saturated MR.
So this is showing intense enhancement. I would think in this age group, this could have been a nasopharyngeal angiofibroma. I would like to look at an axial sections to see the epicenter of this lesion. and also at the T2 sequences.
Give me your diagnosis.
Nasopharyngeal angiofibroma.
So your anatomy is nasopharyngeal angiofibroma. We are at the level of the ethmoid sinus. So let me take over. Now, this is a classical exam case. Now, this is what we call, this clinical was quite leading that something bad is happening. Now, if you look here, this is the ethmoid sinus. Now, you remember that this wall is known as lamina papricia, which is a thin wall. So what happens that ethmoid sinusitis can then spread into the orbit. And there is an entity, we call it subperiosteal abscess. So as the name tells you that the abscess is confined to the subperiosteum, but it extends into the orbit. Key point is that look here, this is the medial rectus, and there is something else here. There is something else, something extra there. So in these kinds of cases, when you see it, then you ask for contrast. So I can give you a CT. In this case, I gave you an MR. Now, if you look carefully, what is happening? That there is enhancement. So technically speaking, whatever on CT is here, it is all enhancing. And here comes the concept of inflammatory phlegmon. The word phlegmon should be in your vocabulary. I've told you in spine, etc. also. You remember we use the word phlegmonous pancreatitis. So similarly, phlegmon is very important here in head and neck. Remember it like this, that phlegmon is an inflammatory mass. It will enhance. When there will be necrosis, then there will be abscess formation. And the ENT surgeons will combine this kind of surgery. They might do it middle of the night surgery if your center deals with it, because they cannot take a risk. There will be a team of ophthalmologists plus ENT surgeons who will operate and drain the abscess. So they are dependent on your report. If you tell them that there is an abscess, they will drain it. But if you say that there is phlegmon, of course, they will wait and see. It is a similar scenario like a liver abscess. Please remember that in a liver abscess, what happens if a surgeon asks you to put in a drain, you will say, let's wait on it for 2 days, let it be liquefied. So similarly is the concept here, and many a times on antibiotics, these will become fine. So this diagram tells you everything. Look at this. So this is that subperiosteal abscess. This is the medial rectus, and it is showing this inflammation, etc. Now, once it becomes liquefied and it projects here, you see this is the optic nerve. So it can be drastic. Middle of the night, they will do surgeries for these kinds of scenarios. Now, another case is this one. Here, what happened was similar. This is a 49-year-old chronic sinusitis, right orbital pain, ecchymosis, and headache. So if you look carefully, there is opacification here, opacification here, opacification here. This clinical is very important, but look at this. This is the medial rectus. Now, this is the medial rectus. This medial rectus is touching the bone. There is something here. So what we did was, we were worried something is happening. We did an MR. And candidate 2, you are going to tell me the findings on this MR. On this MR, this is a T2 weighted sequence. This is a flare of the brain. This is pre-contrast fat saturated, post-contrast fat saturated, post-contrast fat saturated. Candidate 2, what has happened?
There is a flare hyperintensity in the adjacent right frontal lobe. So this could have extended intracranial through the cribriform plate. Right.
So this is the type of case which you are expecting in the exam. Now, if you look carefully, now there was a soft tissue here which is going into the orbit, and this is enhancing, so there is a bit of phlegmon. But more importantly, there is enhancement which goes into the dura. So this, dural enhancement, and there is edema on the flare. So you can use the word cerebritis if you want for this with dural involvement. So this is a classical case where tells you that a few complications, but subperiosteal abscess is a very important case in your day-to-day practice as well as in your exam. Okay, this is a 13-year-old, 3-day history of headache. What is happening? This is post-contrast CT and bone window. Over to you.
On this axial CT, there is area of peripherally enhancing collection seen adjacent to the frontal bone, as well as intra-axial, as well as extra-axial within the calvarium. So the adjacent bone, skull, there is some lucency seen, lytic area with surrounding sclerosis. So this could be a skull-based osteomyelitis, which spread into the adjacent soft tissues.
So what do you call it? Name a name.
Potts-Puffy tumor.
Excellent. So now Potts-Puffy tumor is an entity which is actually subperiosteal abscess secondary to frontal sinusitis. In this era, particularly in the developed world, it is extremely rare with antibiotics, but you might still see it in the developing world. Basically, these children, usually it is in children, they will present with a very hard bony swelling. It will be very hard. And when you do imaging, basically the same thing which we have learned in previous cases. So this is a subperiosteal abscess of the frontal bone, and this is known as Potts-Puffy tumor. Candidate 2. Let me go through it, then I'll ask you some questions. This is a T1. This is post-contrast T1, pre-contrast T1 coronal, post-contrast T1 coronal, T2, and a T2. Now, if you see here, there is an area of high signal here on this T1. And can you describe it and what is your diagnosis? Over to you.
On this MRI sequential images, I see that there is a expansile T1 hyperintense lesion, which is enhancing post-contrast. So considering the nature of expansile lesion and enhancing, I'm thinking of a mucocele of the sphenoid sinus.
And why? How can you say that it is enhancing? It is inherently high signal on this pre-contrast.
It is
Okay, so let me take over. This is a mucocele, and mucoceles can be inherently high signal. Now, if you go, this is from your CNS. In the CNS, there is a differential diagnosis, high signal intensity foci on things which are high T1 signal. And proteinaceous material is one of them. In head and neck, when secretions are sitting there in a closed environment for long, they can be high signal on T1 weighted sequence. So this is high signal, and it has, you cannot commit on enhancement. Simple as that. You can simply say that because it is inherently high signal on T1, I cannot comment on any enhancement. And keeping this limitation in mind, apparently there is no enhancement. It is causing expansion of the sphenoid sinus on the right side. So this is a mucocele. I just wanted to show you these high signal intensity. Now here I am showing you a melanoma. which is high signal. Now, if you see here, fat, proteinaceous material, gadolinium, melanin. So melanin can be melanoma metastasis. Now, please remember that only 60% of melanomas have got high signal. There is a concept of amelanocytic melanomas, which might not be high signal. So in head and neck, choroidal melanoma is extremely important. But having said that, this case had a cheek melanoma. And on a T1 fat saturated, you can see it here. You can see it high signal, and you can see a bit of enhancement also. So this was just for that signal. Now, if you see this CT and MR, just concentrate on this sequence and this sequence, which is a T2 corona. This is a CT corona. What is happening? Over to you.
On the coronal CT reformatted image, there is a soft tissue density lesion extending from the ethmoid to the frontal sinus on the right side, which is T2 hyperintense, and it is expansile without causing bony destruction. So this could be a mucocele.
Yeah. So if you see here, this is a mucocele. In mucocele, what happens is that this is a chronic condition. It might take years to develop. Basically, one of the ostium of the sinus will be obliterated. So, and there is secretions which are accumulated over a span of time. It will cause expansion of the bone, and then rarefication, and then bony. So expansion tells you that something chronic is happening, and then you can see the rarefication or dehiscence of the bone. So this is a mucocele, ethmoid and frontal, and this is from the book. So this sinus has to be ethmoid, and of course, ethmoids, you remember the frontoethmoid nasofrontal duct, it passes through the anterior ethmoidal cells. So when there is a mucocele involving the ethmoid, it can cause secondary mucocele of the frontal. Here is another mucocele of the frontal, but I just wanted to show you once again high signal on T1 weighted sequence. Now, look at this case. There is opacification of the nasal cavity as well as the maxillary sinus. If you look carefully, look at this lamina papyracea, you will appreciate that from here to here, there is expansion of the bone and some destruction of the bone. Even here, you can see some destruction of the bone, and look here. Now on this axial, you can see the same thing. And this is, these are bone windows, and this is soft tissue window. So what is your diagnosis? Over to you.
On this coronal reformatted CTs, considering the extent of the pattern of extending from the maxillary sinus okay, so this is an aggressive condition, could be a fungal sinusitis, since it's hypertensive bony.
And why did you say that it is fungal sinusitis?
Because of the hyperdense nature and aggressive bony destruction.
Okay, so if you see here, paranasal sinuses with bone destruction, and there are 3 types of fungal sinusitis according to the clinical scenario. So acute invasive fungal sinusitis can be seen in immunocompromised patients, and they will present or progress within days to weeks, and they will just die. Orbital expansion. Then there is another one. We call it granulomatous invasive fungal sinusitis, quite common in Middle East and Indian subcontinent. And this is slowly progressive over, more than 12 weeks. And then there is chronic invasive fungal sinusitis, which is slowly progressive, usually with AIDS, diabetes, or steroids. The key point to remember is that in fungal sinusitis, there will be high density material, usually in the center. And when there is associated bony destruction, because it can cause bony destruction, you've got your diagnosis. And please remember the pitfall on an MR. On an MR, what can happen? Look at this case. This is what can happen, because on a CT scan, it is completely opacified. But on a T2, case from American College of Radiology. Now, if you see, just concentrate on the nasal cavity, right? Nasal cavity, and look at these axials. What are your findings, and what is your diagnosis?
There is evidence of prior surgery in the paranasal sinuses. There is nasal turbinectomy, upper and middle on the right side, and uncinectomy. Could be a prior sinonasal polyp, chronic sinonasal pathology for which patient was operated.
Okay, let me take over. If you see here on this CT scan, what is happening, that the nasal septum is destroyed here, it's not present. Now, if you look carefully on this axial, again the same thing. There is crusting, we call it crusting, overlying this. So basically what is happening, we are in a differential diagnosis. This is septal destruction, very important case for the exam. And if you see here, this is from your book, nasal septal perforation. Other than trauma, cocaine is a known cause, but our case is Wegener's granulomatosis. In Wegener's granulomatosis, what happens is that there is vasculitis, and in upper respiratory tract, lower respiratory tract, we know the other systems of the body which can be involved. And please remember that from the paranasal sinuses, most patients will have involvement of the nose, septum, more than turbinates. So tells you that turbinates can also be destroyed. Then it tells you sinuses. The inflammation can go there and will destroy the sinuses. It can extend into the orbits, to the nasopharynx, to the larynx, to the oral cavity, to temporal bone, to salivary glands. And of course, it can go into the brain, etc. So always remember this, and always remember it as a long case also. Now we use the word granulomatosis polyangiitis for Wegener's. I'm showing you a few examples from StatDX just so that you remember various kinds of presentations. In this, there is complete opacification of the nasal cavity. But then, if you see, there is septal destruction. And look at this case. Here, the turbinates, where are the turbinates? They are all gone, they are destroyed. And there is hyperostosis of this destroyed maxillary sinus. A reverse halo sign due to hemorrhage in the lungs. So you can get a sort of a long case like this. Another example where you can see complete destruction of everything, and then this granulomatous tissue going into the orbits, and this one to show you extra intracranial extension. If you see, there is dural enhancement, etc. And in differential diagnosis, cocaine, look at this, cocaine can cause similar destruction of the nasal septum. Okay, let me give you this last case because this was, I think, the last case of PNS. What is this? Candidate 2.
Frontal sinus osteoma.
Excellent. So this is ivory osteoma, which can happen and which is usually high density, usually of no significance. But beware of this in Gardner's syndrome. So a long case can come in which there will be ivory osteoma of the paranasal sinus. And with this, any stigmata of Gardner's syndrome, including, desmoid tumors, etc., etc. We have seen these cases when we did our GIT. Okay, candidate 2, thank you very much.
Thank you, sir.
So we take a 5-minute break, and after the break, candidate 3, you should be with us. Candidate 3, are you with us?
Yeah, can you hear me clearly?
Yes, I can hear you. So you're correct?
Yeah.
Okay, so a bit of a teaching mode before I give you a few cases. So now we are just going to cover maxilla, mandible, and the teeth. Can you see my PowerPoint, maxilla, mandible, and teeth?
Yeah, I can see.
Okay, so for the time being, I'll just continue. So if you see, this is the mandible, and mandible, there is a condyle here. This is the ramus. This is the angle of mandible, the body. This is the mental foramen. This is the coronoid process. Now, again, the mental foramen here. All of you know the teeth, and we have got incisors, 2 of them. Then is the canine, premolars, 2 of them, and then molar. So these are the pictures of all the teeth, and this is the alveolar ridge of the mandible. Now, if you see here, because this nerve, this is a part 1 question. So, and in the exam also, the examiners at times, they point out what is this. So you should know this. Now, this is the mandibular division of the trigeminal nerve. It bifurcates here into a lingual nerve, which is this one. We are not interested here. We don't see it. But the second one, this nerve, is the inferior alveolar nerve. Inferior alveolar nerve goes into the mandible through this foramen, and this is the mandibular foramen. So on imaging, we can see it, and that is why it is important for you. So it goes into the mandible like this, is passes through the mandible, and on the other hand, 2 small branches, they come out here through the mental foramen, which is also visible on imaging. So if you see here, this is an OPG, and actually you can see this, the mandibular canal. So the foramen will be here and the canal will be here. Some people use the word alveolar canal, whatever you want to use it. And then is the mental foramen. And on OPGs, you can see it. For example, here, you can see it. And these are exam questions for part 1. And sometimes the examiner will ask them in your part 2. For example, there's some pathology here, and then the examiner will point out what is this. So you should know this. As far as teeth are concerned, few points to remember that so this is the gum. So this will be the neck, and this is the crown of the teeth, and this is the root. So if you look carefully, you know there will be a black line surrounding the tooth, which is this periodontal membrane, is the black line. And then there is a sclerotic line. This sclerotic line is lamina dura. So if there is a lucency here, if there is, this line is missing, means some process, some destruction has happened. Just like in mandible, we have just seen 2 foramen, mandibular foramen as well as the mental foramen. Now here in the maxilla also are foramen, and these can be asked in your part 1 exam, anatomy exam. So one is this incisive foramen, and second one is here, which is greater palatine foramen, and a smaller one is next to it, which is lesser palatine foramen. So what is happening? In the incisive foramen here, the nerve which passes through is nasopalatine nerve. Here, greater palatine nerve, and here, the lesser palatine nerve. How do you count the teeth? So there are many conventions over the year, but these days people follow this one, where you start counting the teeth. You number them from 1 to 32. From 1 to 32. So the key point to remember is where is the 1 and where is the 32. So the how to count maxillary right third molar is number 1. So this is number 1. From here, start counting. This is the upper jaw. So start counting like this and then go down. So this will be 1. This will be 16. And so if you see here, this is the right side. So this will be 1. This will be 16. And then 17, 18, 19, go like this. So this is the current method to count the teeth. Having said that, nobody is stopping you just to describe. For example, if there is something happening here and you want to say that, second molar on left side, mandibular molar on left side, it's fine. So this is a CT scan. This is a part 1 scenario. You can see this incisive canal, and this is the greater palatine foramen. This is the lesser palatine foramen. And so on a coronal, please remember that this is in continuity with the greater palatine canal and the Pterygopalatine fossa. Here again, the same, the method of counting the teeth is depicted here, which we don't have to repeat. Okay, now a few viva cases for you. Rapid reporting. Normal or abnormal?
It's abnormal. There is temporomandibular joint dislocation bilateral, I think.
Excellent. So if you see here, basically the anatomy is that this is the mandibular condyle. This is the articular eminence of the temporal bone. This is the fossa. This thing should be sitting here, and this is the external auditory canal. So this is displaced anteriorly. Similarly, this should have been sitting here, and this is placed anteriorly. So this is bilateral TMJ dislocation. Normal or abnormal?
Abnormal. There is left-sided temporomandibular joint dislocation.
Excellent. So if you see here, if you see, this is the ramus and this is the condyle, something is abnormal, and this is sort of sitting here, displaced on itself. So if you compare right and left, then you pick it up. Yes, please. Normal or abnormal? So don't worry about this because we knew this.
It's abnormal, left-sided TMJ dislocation.
Yeah, actually, this is the same patient. This is the same patient. And interestingly, in this case, this was missed. Clinically it was evident, but radiologically somebody missed it. And then OPG, you can see it is sitting here, and this is abnormal. Normal, abnormal?
Abnormal. There is left-sided temporomandibular joint dislocation and probably on the right side too. So bilateral dislocation TMJ.
Excellent. So this thing should have been sitting here. This thing should have been sitting here. Bilateral TMJ dislocation. Can you describe the findings here?
There is a unilocular. This is the lateral radiograph of the head and neck. There is a unilocular non-expansile lucency around the apex of the, I think it's the apex of the tooth on the right side. No evidence of any other lytic or sclerotic lesions or pathological fractures. The findings are suggestive of a radicular cyst. The less likely differential if the patient has raised inflammatory markers and fever. My differentials would be a periapical abscess or a periapical granuloma.
Okay, good, well done. So the only thing is that it's an oblique view. Now, if you see here, radicular cyst is one of the most common. If you see here, this is from your Chapman, bony lesions or mandible maxilla cystic. Most of them are dental origin. Periapical or radicular cyst, well-defined ovoid, less than 1 centimeter cyst at apex of dead tooth due to inflammation and necrosis from dental caries, often visible as erosion of the crown enamel. Most common odontogenic cyst. So if you see here, if you see the crown, it is eroded. And with that, at the root, you can see that there is a cyst. So this is a radicular cyst. Can you describe this for me?
This is over the spot radiograph of the OPG. There is a similar unilocular non-expansile lucency around the apex of the right maxillary molar. No evidence of any pathological fracture. Response normal. So findings are likely suggestive of radicular cyst.
Did you mention the crown?
Sorry, it's around the apex of the tooth.
No, the crown. Did you mention this or you did not?
No, I didn't. There is erosion of the crown as well.
Please remember that should be part of the exercise. If you see here, often visible as erosion of the crown enamel. So crown, it's common sense, right? That this can also be. So even the first case, if you see here, look at the crown. There was erosion there. So all radicular cysts, the crown might not be eroded, but it should be part of your exercise to comment on this. And if it is eroded, call it. So if you see here, this lucency is what we were talking about, the lamina dura, and that is gone here. So this is another radicular cyst. Can you describe this for us?
This is the one of the zoomed image of the OPG focusing on the right side of the mandible. There is a large unilocular expansile lucency around the adjacent to the unerected tooth on the right side, adjacent to the right third molar. This is likely suggestive of a dentigerous cyst.
Okay, excellent. So if you see here, dentigerous cyst. It is a developmental cyst associated with crown of an unerupted or impacted tooth, most in mandible, especially the third molar. Variable size, usually unilocular with thin sclerotic margin. Maxillary cyst expand into the maxillary sinus. No enhancement or solid component. No enhancement or solid component is important for you to remember, because at times, this tumor, which is known as ameloblastoma, can also be associated with an unerupted tooth. But having said that, when you give contrast, there will be enhancement, enhancing neural nodule or septi, etc. So that is a key point to remember. Now, this is another case of dentigerous cyst, where you can see this expansion here. This is from your book. Yes, please, over to you.
These are the two spot images of the axial and corneal images of the focusing at the level of the mandible bone window. There is an ill-defined large multilocular expansile lucent lesion involving the right side of the body and ramus of mandible, which is causing the scalping, thinning, and pressure erosions of the underlying bone with resorption of the underlying teeth. There is no evidence of any definite fracture, calcifications, or adjacent soft tissue mass. The rest of the bones are normal. So this is likely suggestive of a non-aggressive etiology, a likely ameloblastoma. Next, I would like to view the soft tissue window as well, and would inform the dental surgeons, head and neck surgeons, maxillofacial surgeons for further evaluation.
So if we see here, there are internal septations, and this is the soft tissue. This is the post-contrast soft tissue. What do you think? What is your final conclusion?
Ameloblastoma.
Okay. Did you use the word non-aggressive lesion here?
I think it is aggressive because it is causing the pressurization and thinning and resorption of the teeth. So it's like an aggressive etiology. Yeah.
Right. Please remember, ameloblastomas are definitely locally aggressive. Most of them are benign, but there is a entity, we call it amelocarcinoma. So that is known to occur also. And actually, if you see here, ameloblastoma, malignant transformation 1%. So in this case, what are the key points? Key points is benign, locally aggressive neoplasm arising from tooth-bearing area of jaw, 30 to 50 years, most in mandible, near third molar and ramus, and usually soap bubble or bubbly appearance. So, and this picture tells you everything. Where is that picture? You see this soap bubble. So this is ameloblastoma. But of course, in the real world, you will have to give a bit of a differential diagnosis. Other than ameloblastoma, what can it be?
Odontogenic keratocyst.
Yeah, and odontogenic keratocyst. So no solid nodule or mass. You see this thing? No solid nodule or mass. So even if you want to consider it, then you rule it out. Rule it out. Because if the examiner says what else can it be, so then you rule that out. So this is the differential diagnosis which you can see from here. You know, other malignant lesions, you know, metastases and things like that, of course, you might like to consider them. But the counter argument is that metastasis will cause destruction. It will not cause expansion like this. So something was sitting there which was basically causing expansion, and then means it is low grade, whatever it is. This is another case of ameloblastoma, which shows enhancement here, just to make a point that they have got what we call solid component. Now, there is a differential diagnosis which is not in the current Chapman. This is a plain film type of a differential diagnosis. It has come in the exam quite a few times, so I just wanted to show you one case. Floating teeth. Now, the concept of floating teeth is, this is the differential diagnosis from your previous Chapman. So what happens is that the gum and you know, the margin of it is sort of eroded, or it might be very you know, osteoporotic. So radiologically speaking, it's not visible, and a radiograph will tell you as if the teeth are floating in air like this. So severe periodontal disease, Langerhans histiocytosis, hyperparathyroidism. These two are very important. Langerhans histiocytosis, hyperpara. So the idea is to remember this appearance, because if you have not seen it, you will be absolutely surprised what is happening. We call it floating teeth. Normal, abnormal?
It's abnormal.
Yes, please.
There's fracture of the orbital wall on the right side, inferior orbital wall.
Excellent. So if you see here, this is the maxillary sinus. This maxillary sinus is not normal. And so this is zygomatic fracture. And there is another from a 3D volume rendered. Just to make a point, this is another case. This is zygomatic fracture. The same case on that was a slightly paranasal sinus view. This is an AP view, and you can see the same thing here. Can you describe this?
Yeah, there are multiple fractures involving the bilateral medial and lateral pterygoid plates, as there is also a mildly displaced and linear non-displaced fracture of the right frontal bone. So this is likely one of the subtype of Lefort fracture. So I would like to, in my routine practice, I would like to review the rest of the images to further characterize the type.
Excellent, well done. So let me recap the concept of Lefort injuries. Please remember, Lefort described them. He used skulls, he produced various types of traumas, and he picked up some lines of weakness. In the real world, at times there is a mixture, and so these, this concept is, many people don't use this concept. Having said that, just to revise it, basically there are three types: Lefort 1, Lefort 2, Lefort 3. One key point to remember is that in all Lefort injuries, the pterygoid plates will be definitely involved. It can be unilateral or bilateral. So please remember that, number one. In Lefort 1, look at this picture. It tells you everything. The line of fracture goes through the maxilla and then transmits posteriorly through the pterygoids. So what will happen, that you will see this alveolar ridge of maxilla. If you hold this patient's upper teeth, you will see that they will be slightly mobile. So this is Lefort 1. So this is the fracture line passing through the alveolar ridge of the maxilla. In Lefort 2, what is happening that the line passes through the maxilla and the medial wall of the orbit. So indirectly, the whole of the maxilla becomes free. In the first one, only the alveolar ridge was moving. Here, whole of the maxilla becomes free. And in the third one, what happens, that other than the medial wall, the lateral wall of the orbit is also involved. So this is known as craniofacial disjunction. So basically, whole of the facial skeleton will be sort of mobile, and there will be a disjunction between this and the cranial cavity. So can you describe the findings on this one? Over to you.
So there are bilateral fractures of the lateral pterygoid plates. I'm looking at the rest of the bones. There is a pyramidal shaped fracture is seen involving the pterygoid plate. There is a fracture of the inferior orbital walls, the bilateral lateral pterygoid plates. There is fracture of the anterior wall of the right maxillary sinus, bilateral nasal bones, and comminuted fracture of the symphysis mendae. No involvement of there is some diastasis of the right frontal zygomatic suture, where the hemosinuses involving the bilateral maxillary, ethmoid, and the sphenoid sinuses. So this is likely suggestive of a Lefort fracture, and the type is likely 2.
And considering if this is present, then it will become a 3 on the right,
3. Yeah.
Left. Yeah. This, on the other hand, is bilateral 3.
3.
Yeah. If you can see here, pterygoids, the medial wall is gone, and the lateral wall is gone, pneumocranium, etc. Yes, please.
So this is this a rapid reporting film?
Say again,
Is that a rapid reporting? Sorry, it's a Viva case. So this is in X-ray skull AP view. There is non-visualization of the left innominate line representing a bare orbit.
Maybe projectional. The patient has got history of trauma. Over to you.
Okay, there is right inferior orbital wall fracture with the pacification of the right maxillary sinus.
Excellent. So why I'm showing you this, because one of my registrars got it a few years ago. In the Viva, I was surprised. So it was the first case in the Viva, and so it's a black and white, what we call blowout fracture case of the inferior wall. And this is a CT scan. Basically, what happens is that in these blowout fractures, there is another case here. What happens is that the inferior wall of the orbit is a thin wall. Similarly, by the way, there can be blowout fractures involving the lamina papricia also. So basically, there is increased pressure here. And let's say somebody, a ball hits here or a punch hits on the orbit, and the fracture will be here. So the point was just to pick up this blowout fracture, the teardrop sign. So this is a recap of the anatomy, which we have already done last time. But let me ask you leading questions. This is a case of nasopharyngeal angiofibroma in a 16-year-old. These are T1 weighted axial sequences post-contrast. Where are we here?
Sphenopalatine foramen.
No, foramen. You see, this is the sinus.
This is sinus, so it's posterior to sinus is the Pterygopalatine fossa.
This is the fossa. Now, the connection between this nasal bone and this thing, there is a foramen here. What do you call that foramen?
Sphenopalatine foramen.
Excellent, sphenopalatine foramen. Now, this is the masticator space, which is the nasopharyngeal masticator space. Now, this space opens automatically, the pterygopalatine fossa opens here. So, what do you call this, this opening? What do you call it?
If it's inferior, then we'll call it Vidian canal.
I'm talking about lateral.
Okay, lateral is foramen rotundum.
Lateral. You see, you are confusing because I'm not right now. This is the pterygopalatine fossa. I'm asking you a normal anatomy question. Lateral to the pterygopalatine fossa, here will be the nasopharyngeal masticator space. So this opening is known as question mark.
Sorry, I'm unable.
No? Okay, let me. Now, if you see here, this is a CT scan of the same case. Now, relevant anatomy is, now this is, first of all, look at this is the normal side and this is the abnormal side. So you can see that there is a tumor, nasopharyngeal angiofibroma. It arises from the nasal cavity. From the nasal cavity, there is a foramen, which is known as sphenopalatine foramen, and it goes here. Now, once it goes here, it is projecting or displacing the posterior wall of the sinus anteriorly. Now, what I was asking was that here, this is the nasopharyngeal masticator space. This thing is pterygomaxillary fissure. Pterygomaxillary fissure. And now, posteriorly, this thing is going to communicate with the cranial cavity. And so there are two communications. One is the Vidian canal, and another one is the foramen rotunda. So, and inferiorly, it is going to communicate with the, if you see here, we are at the normal side and we are heading towards here you are. This is the heart palate, the last slice. So this is that greater palatine foramen, and I'm going up again. Here, there will be, this is the Vedian canal, and at a slightly superior level, there will be foramen rotundum. In this particular case, the slices are slightly thick. So we will go to, so this is the Pterygopalatine fossa. Anterior, here it is communicating with the inferior orbital fissure with the orbit. Now posteriorly, it will communicate with the middle cranial fossa. So if you see, the key point here is that this is the sphenoid sinus. This is the Vedian canal, and you can see that the Vedian canal is expanded. And on the other hand, this is the foramen rotundum, which is on the lateral sides. Okay, so thank you very much.
Thank you, sir.
Okay, candidate 4, are you with us?
Yes, sir.
Okay, so we are covering oral cavity, masticator space, sublingual. So masticator space we have already done, and parotid space we have just done. Basically, we have to do the oral cavity, which includes the sublingual and the submandibular space. Yes, please. What is this?
I'm provided with one of the spot images from submandibular shallogram. What I can see is there is multiple dilatation of the intraglandular ducts. I can also see that there is large soft tissue lesion within before the opening of the submandibular duct into the oral cavity. But I'm not sure about that. But the intraglandular dilatation would likely represent salutasis of dilated intraglandular ducts. I would like to ask for the history of the patient if he's having some fever and inflammatory marker array. So I will be thinking about the infection, but I'm concerned about this dilated duct in proximity as well. So I would like to investigate it further with cross-section imaging.
So what do you think is happening here?
There is something sitting within the submandibular duct. So
what will you ask for? What will you do? You have asked for functional imaging, but before that,
I would ask for. I would like to correlate with the history of the patient. It can be a collection over here as well. Like it can be.
Hint. Think IVU.
There can be a filling defect over here as well.
So
it can be a stone, a big stone here. Which is causing obstruction, and there is.
My point was that do you diagnose some filling defect on a IVU just on that film, or you ask for something?
No, I would ask for. I would like to have ultrasound of this patient.
Ultrasound.
Yeah, gaze scale imaging of this patient of neck for correlation.
IVU. Do you ask for any other film?
Scout image. Yeah, definitely scout image. Yes. Yeah, there's a big stone sitting over there. Yeah.
Okay. Okay.
Yeah. Okay.
So basically, this is a submandibular shallogram. Now, there is a concept of sialactasis. When there is obstruction of the duct, there will be dilatation of the duct. So sialactasis has got causes like obstructive sialactasis or non-obstructive sialactasis. Here, if we see one thing which was well picked up, that this is submandibular sialogram, because look at the configuration of the cannula, which goes down like this. But the key point was that basic thing which is asked for a scout or a plain fill. Now here, similar case, what are the findings? It is not the same case. What are the findings on right side?
I can see that there is enlargement of right submandibular gland with minimal post-contrast enhancement. I'm looking for submandibular duct. Yeah, I can see that there is a hyperdense lesion seen in the vicinity, likely representing a stone which is going within, this one, yes. So likely representing an obstruction within the submandibular duct, which is causing inflammation in the submandibular gland on the right side.
And how will you confirm that this is a stone?
Because it is of calcific density, that's why. Or how can we, I'll see it on the bone window.
Yeah, basically you will check the Hounsfield unit, or you can, because the point is that
It can be
a vessel. Can it be a vessel here?
Yeah. Normally there is no vessel sitting like this peg over here, but I would like to see it on bone window. It will confirm my finding probably.
Excellent. Okay, so let me go back to a bit of anatomy teaching mode, then we will come back. So candidate,
Yes, sir.
is the PowerPoint visible to you? Oral cavities.
Yes.
So
Yes, sir. Yes.
yeah. So now I'm just going into a teaching mode. So I'll come back to you. Now, oral cavity is made up of various spaces, and you should have a clear-cut idea about this concept, because the differential diagnosis will change according to that. One is the mucosal space, which is the lining of the oral cavity, which is clinically evident. Sublingual space, and then submandibular space. And these are the main contents of the sublingual space. Sublingual space is the space which is superior to the mylohyoid muscle. Submandibular space is inferior to the mylohyoid muscle. Important point here in the sublingual space is that other than the sublingual gland, we have got the submandibular duct there, just like our case. Second thing is that the deep portion of submandibular gland is here. And in the submandibular space, most of the submandibular gland is there, but the deep portion is in the sublingual space also. So, few other points. Anterior belly of digastric muscle is a part 1 question. I'll show you what it is. Now, if you see your Chapman, in Chapman, the differential diagnosis in the oral cavity have been divided into 4 actually. And this also tells you the concept. Oral cavity 12.12, oral mucosal space lesions. Then 12.13, oral cavity sublingual space lesions. Then 12.4, submandibular space lesions. So this is submandibular. And then finally, there is root of tongue lesion. And I will tell you what is the difference between root of tongue and tongue base. And many people confuse it. So root of tongue is within the oral portion of the tongue. And basically, contains genioglossus, and geniohyoid muscle, as well as the lingual septum. So just please remember from here, root of the tongue means the oral part of the tongue, which is the muscular part. End of story. Base of tongue is a separate concept, which I'm going to elaborate in the next few slides. Now, key point when you have to have a very clear-cut idea of what is oral cavity. And please remember, oral cavity is different from oropharynx. And the key differentiation is the boundary between the oral cavity and the oropharynx. Oropharynx we are going to cover next time. Today we are just covering oral cavity. So if you see this this blue line, this is oral cavity, which makes sense that, this is the tongue, the alveolar ridges, mandibular, and of course, the maxillary. These are the cheeks, right? Now, posteriorly, this is the tongue. The landmark is that on the posterior portion of the tongue are taste buds, which are known as circumvallate papillae. These are quite prominent. I'll show you more pictures. So this is the posterior most extent. Circumvallate papillae are in the oropharynx, not in the oral cavity. And there is another mucosal fold here, which is known as anterior tonsillar pillar. And so posterior to that is the oropharynx. Now, I'll come back to that concept, but first of all, look at this mylohyoid muscle. This is the mylohyoid muscle. Mylohyoid muscle is the base of the oral cavity. It is just like equivalent to, in the pelvis, we have got a levator ani, similar. So it is attached into the anterior surface of the mandible. And superior to that here is the sublingual space. Inferior to that is the submandibular space. Key point to remember that most of the submandibular gland is sitting inferior to the mylohyoid, except for the deep portion. But key point to remember is that the submandibular duct, it actually goes into the sublingual space. And that is why the duct is seen here, and that is why we cannulate it when at this part of the anatomy when we do a sciallogram. So this is the sublingual gland. Now coming back to, so this green space is the sublingual space, and this blue space is the submandibular space. Now, if you concentrate on this coronal sequence, it tells you a few points to remember. Now, this green space is sublingual space. Look at this muscular structure is the tongue. Tongue has got two types of muscles. One is intrinsic muscles. So most of this, what we are seeing here is intrinsic muscle. And then is the extrinsic muscle. The concept of extrinsic muscles are that these are muscles of the tongue, which of course they constitute the tongue, but they are attached somewhere else. Intrinsic muscles are not attached anywhere else. Now, two muscles should be in your vocabulary. One is this genioglossus. You see this? Genioglossus. Another one, hyoglossus. But if you concentrate here, look at this sling. This sling is the mylohyoid muscle. Now, here is another muscle, which is a part 1 muscle, anatomy exam muscle, anterior belly of the digastric muscle, which is in the submandibular gland. Key point to remember is it will be inferior to the mylohyoid. There is a muscle here by the name of geniohyoid, which is not by definition an extrinsic muscle of the tongue. This is in between this and the tongue. At times it is difficult to pick up on an MR or a CT scan. So, but mylohyoid and inferior belly of the digastric, you must remember that. So this is what we see when clinically speaking, we are looking into the mouth, uvula, and these are the pillars we are talking about. This is the anterior tonsillar pillar, and this will be the boundary. Now, if you see here, this is a sagittal diagram. This is the tongue. So this is the hyoid bone. And somewhere here is the circumvallate papillae. This portion of the tongue, which is projecting posteriorly, this is known as tongue base. So this is tongue base, and this is portion which is part of the oropharynx. You see here, this is tongue has got two portions. One is the oral portion. This is the oral tongue, and this is the base of tongue, which is part of the oropharynx. So we will learn this next time, but this is our curriculum today. And this part of tongue has got intrinsic muscles and extrinsic muscles. And so this pillar is the boundary. Here is circumvallate papillae on the tongue, and this is plateau-glossal arch, also known as anterior pillar of the tonsil. So if you see another view here from the superior side, these are the circumvallate papillae. So anterior to that is the oral tongue. Posterior to that is the tongue base, etc. And so that is not part of the oral cavity. Look at this fold here. This is the anterior pillar. So this posterior to that, all of this is oropharynx. So once again, the same concept. Anything which is blue is the oral cavity, and this is the oropharynx. And once again, favorite exam muscle is anterior belly of the digastric. So look at this diagram. The posterior belly arises from the mastoid process. It goes and attaches to the hyoid bone. From here is the anterior belly, and anterior belly is a part of the submandibular space. So on a coronal sequence, it will be inferior to the mylohyoid muscle. Now look at this. This is the genioglossus. You see, most of the tongue is here. This is the extrinsic muscle, and this genioglossus at times gives you this septated appearance. Another muscle which is fan-shaped like this bilaterally, this is the hyoglossus. Rest of the muscles or extrinsic muscles of the tongue, like plateauglossus, like stologlossus, radiologically speaking, you cannot see them. But this genioglossus and the hyoglossus should be in your vocabulary. So if you see this coronal, these muscles here are the genioglossus. This one and this one is the hyoglossus. Now, so this is an MR, intrinsic muscle, and this is genioglossus. So look at this CT scan, the lingual tonsil here. Just concentrate on the muscles. So this is genioglossus. And this one here is the mylohyoid muscle. This space here is the submandibular space. This space here is the sublingual space. So again, all of this is sublingual space. This is the genioglossus muscle, and this is the submandibular space. Once again, genioglossus, sublingual, and all of this is submandibular. Submandibular space will go till the level of the hyoid bone. And another key concept to remember is that submandibular space is continuous with the other side. So it goes all the way to the other side. There is no boundary or no division or no septum here. This is the anterior belly of the digastric muscle. And next slice, you can see the hyoid bone is here, submandibular gland, submandibular gland. And you can see here the same concept, that submandibular space is here. It goes all the way. And this is the inferior belly of the digastric. So we are running out of time, but I think we will continue for next 10-15 minutes. So let me go through this anatomy on this MR. So if we marry it with T2, just to orient you. So if you see here, this is the tongue, this is the epiglottis, this is the soft palate. So from here to here is the base of the tongue, and this is part of the oropharynx. This area is our area of interest. So if we just now, as I'm passing through this part, you see this part, the tongue is coming to view. By the way, candidate 4, you can see my DICOM.
Yes, sir.
Okay.
Yes, sir.
So you can see this tongue here. So this has to be the intrinsic muscles of the tongue. So this is tongue, this is the septum. Tongue has got some fat also, and that is why on a T1 weighted sequence you see it very well. And if you do some staging of tongue carcinoma cases, please remember, if a tumor extends through this septum to the contralateral side, it becomes a T4 tumor because they have to remove the whole of the tongue. So on this fat, non-fat saturated T1, at times you can see it much better because of inherent contrast, because of fat inside. Look at this septum. So right now we are passing through the intrinsic muscles. Now we are coming inferiorly. Now you can imagine that there is a muscle here. You see this thing? This thing. So this has to be the genioglossus muscle. And do you see this thing here and this thing here? So this has to be the geniohyoid, you know, right and left. So this is genioglossus. Now this part, you see, we are here. So here, this is all sublingual space. Sublingual space. Now let's orient ourselves with the mylohyoid muscle. So do you see this? This is the mandible. So this muscle here has to be the mylohyoid. Now if you look carefully, the submandibular gland is here as I'm going inferiorly. So the submandibular is here, and then comes the hyoid bone. So the submandibular finishes. I'm going superiorly once again, and you can see portion of the deep portion is here. If you stretch your imagination, this is the axis of the submandibular duct. So this is the sublingual space, and this space is the submandibular space. So let's try to identify the anterior belly of the digastric. So first of all, let's see the posterior belly of the digastric. Now here is the mastoid, and this is the parotid gland. So the posterior belly will arise where I am pointing out. This is the posterior belly. It is going just medial to the parotid. You see, it is going, this thing is the posterior belly. It goes down, goes down, goes down, and then this is the hyoid bone. So from here will be the anterior belly. You don't see everything very well. but once you know your anatomy, you can make it out. So this has to be the digastric muscle, or was it the platysma? Let's see. Let's go to a coronal. So this is a coronal sequence. Now, do you see this from here to there's a muscle here? So this has to be the anterior belly, and this is the mylohyoid sling, and then everything becomes a bit difficult to see. So this is the septum, genoglossus, sorry, and here is the genohyoid muscle. This is the intrinsic muscle. This is the submandibular gland. So this is the anatomy of the what we call so anatomy is finished, and let's go for a few Viva questions. So, candidate 2,
Yes, sir.
correction, candidate 4. You can see my PowerPoint, submandibular duct calculus.
Yes, sir. Yes, sir.
Okay, so here, just to see this picture, and this is the submandibular gland, and there is a calculus here, and there is some dilatation. 2 other examples, calculus here, calculus here. This is a MR, and just to make a point that on MR, there is a stir sequence here. You can see high signal on the submandibular gland on right side. If you look carefully, this is the submandibular duct, and you can see a filling defect here. It is confirmed on this CT scan. So another case of sialadenitis, secondary to a stone. Okay, can you tackle this, please?
Yes, sir. I'm provided with spot images from a parotid cellogram, and what I can see are there are multiple dilatation of the branching ducts. However, I cannot see any filling defect on either of them. So, likely representing the sialectasis, parotid sialectasis.
So what will be the cause for this?
It can be it's due to autoimmune perotitis.
Okay, fine, well done. I will take over. Now, basically, sialectasis means dilatation of the ducts. So there is a main duct and there is branch duct, and the branch duct can be dilated. You don't have to remember what is written here, but people classify it that if punctate, globular, cavitating, complete destruction of parenchyma, I think you should remember this. So basically less than 1 millimeter, between 1 and 2, more than 2, and destruction of parenchyma. Now, there is a concept of obstructive sialectasis. You know, for example, if there is a stone or there is a tumor or a stricture, etc. On the other hand, there is non-obstructive sialectasis, which is more important for your exam. And this usually, the non-obstructive sialectasis, the most common cause is autoimmune disorders, Sjogren's syndrome. And in Sjogren's syndrome, please remember the concept, and from there, long cases can come in your exam. You remember the definition is that primary Sjogren's, in which there is dry eyes and dry mouth, and then there is secondary when there is some associated connective tissue disorder. What are the associated connective tissue disorders? For example, rheumatoid arthritis, SLE, and systemic sclerosis, as in scleroderma. So what can happen in the exam that you can be given long cases in which there is a film of sialactasis, and with that there is another film of something else, and any of these conditions can come. So this is an MR, and if you see, this is not a scialogram series, but even on this stir sequence, you can see all of these ducts, they are dilated. They are dilated. So here, this is a parotid lesion, which I just wanted to highlight the perineural spread of tumors in parotid, and we have done this case when we did the temporal bone. So I just wanted to highlight, because in parotid lesions, particularly when they are, here is a deep lobe lesion. This was an adenoid cystic carcinoma of the deep lobe of parotid, and the concept is that the tumor can go through the facial nerve all the way into the internal auditory canal. And so there is an example here where this happened. And in our example, there was a connection with the fifth nerve also, and it went to the foramen ovale, perineural spread. We have seen this case previously. Okay, over to you. What is happening here?
I'm provided with CT image. What I can see is there is bilateral parotid glands are swollen with multiple hypointense lesions within, likely representing an autoimmune fossa that is involving the bilateral parotid glands. So I would like to correlate with the history of the patient if he is having.
That's fine. Well done. So what do you think has happened here? Pathologically speaking, what are you looking at here?
Probably autoimmune parotitis, and multiple cysts are there, but I would like to ask of the age of the patient.
Okay, let me take over. You remember these words. This is complete destruction of parenchyma. Simple as that. It is the stage 4 of sialactasis, where there is no parenchyma, there is cystic change, cystic dilatation, and there can be lymphocyte aggregates with it, which you will find it difficult to differentiate from any tumor. So this is destructive type of sialactasis. And so here is another example where you can see this dilatation on a T2 weighted sequence, and there was a nodule which enhanced. Actually, in these cases, what happens is that there are lymphocytes aggregates which will give you this nodularity. You will have to do a biopsy to rule out any malignancy, but usually it is benign entity. Okay, now this case is a long case, and first of all, if you see here, what is happening in the parotid glands? What is happening in the submandibular glands? Over to you. What is happening in the nasopharynx?
Let me start with it. I can see that there are multiple cystic changes seen within both submandibular as well as in bilateral parotid glands, and in the nasopharynx.
So what is happening here?
There is there is I can't make it.
Is it normal? Is it normal?
No, it doesn't seem normal because it's a fat set image and there are some hyper intense signals are seen within it. So
what is happening here? What is happening?
There are multiple multiple lymph nodes seen along the bilateral.
Okay. Now, same case, you've got a tumor in the brain.
Okay, it can be due to there are multiple lesions involving the splenium of corpus callosum, and I can also see there are multiple lesions in occipital lobe as well. I would like to ask for the if patient is immunocompromised, because
The patient is immunocompromised. Over to you.
then it can be due to the age-related lymphoepithelial disorder with involvement PML in the brain as well, because I can see there are lesions at the corticomedullary junction as well in the occipital lobe. So with a multiple
Forget about what is happening in the neck. If you just tackle this case here, these are flare sequence, and this is a diffusion weighted, this is a post contrast. What is happening here?
There are multiple hyperintense lesions on flare, and I can see that they are showing peripheral post-contrast enhancement, and some of them involving the splenium of corpus callosum, and I can see that there is one lesion which is present at corticomedullary junction. So
what will be your unifying diagnosis on this one? Just on this one.
PML?
The corpus callosum. Hint. Corpus callosum is involved. Then
it can be a lymphoma.
Okay, I'll take over. Well done. So, this is an entity which is known as benign lymphoepithelial hyperplasia. And you have to know this entity to be able to diagnose what is happening. Now, benign in HIV positive cases, the patient might have AIDS or might not have AIDS. This is what happens. Basically, what happens that there are multiple cysts in the parotid gland, number one. Number two, there will be adenoid hyperplasia. So this is adenoid hyperplasia on an axial. It is bilateral symmetrical. And then there will be cervical lymphadenopathy. In our case, there are cysts in the submandibular gland. I've seen two cases. If you see literature, usually it will tell you that in benign lymphoepithelial hyperplasia, there are cysts in the parotid gland. But in my collection, there are two cases in which I've seen cyst in the submandibular also with this. So you have to know this condition, benign lymphoepithelial hyperplasia. Sometimes there can be solid nodules also in the parotid. Look at the word benign. So please remember, even in HIV positive or AIDS positive cases, this is a benign entity. So, and of course, in this case, there was a lymphoma with that. Which space is involving this lesion?
Sublingual.
So what is your diagnosis?
It can be a ranula.
Excellent. Now, what is a ranula? Ranula is what we call ranula is a retention cyst and basically in the sublingual space there is a retention cyst of the arising from the gland, and it will have thin walls, it will not enhance and things like that. So this is known as a ranula, and usually it will be in the sublingual space. Now, what is this? Over to you. This is an exam case.
Okay, there is a large cystic lesion seen in relation to on the right side of the neck in relation to the submandibular gland. In this neck, likely because it's a cystic lesion and look benign to me, so likely representing a brachial cleft cyst.
Hint. Look at the sublingual space.
Yeah, I can see that there is dilatation of the duct as well. So
is it the duct? You see this and this?
No, it's not a duct. This is a buccal mucosa probably which is inflamed, and I can see some hypodense areas over there, and there is a large collection here, so likely representing an abscess with
There are two
infection.
signs of an abscess, clinically speaking.
Sorry,
Hint.
it's a painless neck mass.
You remember your first case?
Yes, it can be. It can be submandibular gland cyst. I'm
Your
sorry.
first case. What was the first case which you just did? This one.
Yeah, that was a ranula.
So that is the hint.
That is a retention cyst as well, a submandibular gland. I haven't seen it before.
Okay, let me take over. Now, anatomy, this is what we call a plunging ranula or a diving ranula, and this is a classical exam case, which I am showing you. Basic concept of anatomy is that please remember the sublingual space. So if you imagine the mylohyoid sling is here. Now the sublingual space is connected with the submandibular gland posteriorly here. So basically there is no boundary. Now what happens is when there is this retention says a basic concept is that it just bursts. When it will burst, it will go over the sling and go into the submandibular space. The key finding is that part of it is still seen in the sublingual space. We call it the tail sign, as in TAIL, tail sign. So this is the tail and this is the ranula. Without this tail sign, you can never diagnose this. And this tail sign is pathognomic. It is an aunt mini, because otherwise this is an extremely important differential diagnosis, which is the differential diagnosis of a cystic lesion in the submandibular region, which is an extremely important exam case. I'll show you other examples, but this one is with this tail sign. So this is a plunging ranula, also known as a diving ranula, whatever you want to call it. So part of it is in the sublingual space, part of it is in the submandibular space. And so this differential diagnosis should be in your mind. It is extremely important. This is in your book, there is a differential diagnosis of submandibular space lesions, but it does not discriminate between cystic and solid. So take a screenshot of this one. Diving ranula, second branchial cleft cyst, as you were talking about, submandibular abscess, necrotic node is extremely important, lymphangioma, dermoid, and epidermoid. So if you see here, this is a branchial cleft cyst. The classical location of a branchial cleft cyst is in between the submandibular gland and the sternocleidomastoid muscle. So this is the sternocleidomastoid, this is the submandibular. This is the second branchial cleft cyst. And this case, on the other hand, what has happened to this branchial cleft cyst on this post-contrast candidate 4?
It's enhancing, it's infected.
Yeah, so this is another classical exam case where the second branchial cleft cyst, classical location between the submandibular gland and the sternocleidomastoid muscle, it is showing enhancement. And please beware of necrotic lymph nodes. And I've seen 2-3 cases in my career where it was missed, and that is a big mix, because necrotic lymph nodes will be malignant lymph nodes. Look at this. On ultrasound, we have got something inside, and is it a branchial cleft cyst? And when we give contrast, you can see that there are internal septations, some enhancement. So this was a malignant lymph node instead of second branchial cleft cyst. Okay, last few cases, what is happening here?
27-year-old with a history of gradually increasing stimulus lump under the chin. There is a lesion in the sublingual space with internal areas of hyperdensity. Likely representing involving the sublingual gland over here. in this phase.
Hint. First hint is that is it crossing the midline? It is going right and left, correct?
Yes, it is
Fully.
crossing the midline.
Number 2 hint. If you see the Hounsfield unit, what do you think is the Hounsfield unit of this?
It can be fat.
Okay, so what is your diagnosis?
It can be epidermoid.
Epidermoids do not
Derm-
contain fat. It
Sorry,
is dermoid which will contain fat, right?
Yes, dermoid.
Dermoid. So please remember that dermoids can be within the tongue. Dermoids can be in the sublingual space also, outside the tongue. Both dermoids as well as the epidermoids. If you see here in your book, sublingual space lesions, and it will have dermoids and epidermoids. And similarly, they can be in the tongue also. Beware of this kind of a case. This is a case, I'm showing you a brain MR actually, and on sagittal sequences, you can see a dermoid sitting here. You see this thing?
Yes, sir.
So, high signal on T2, high signal on T1, and on CT scan, there was of course fatty density, and this fatty density is minus 61 Hounsfield unit. So do you see this in your Chapman? Root of tongue lesions, dermoid and epidermoids can happen there. So please remember that oral cavity, dermoids and epidermoids. I've shown you this case previously, but this is what we call motor denervation. And in motor denervation, what happens is, please remember that hypoglossal nerve, 12th nerve, it supplies the muscles of the tongue. Now, if the hypoglossal nerve is affected by a tumor, usually at the jugular foramen or in the carotid sheath, then what will happen? The nerve supply to the muscles will finish. And what will happen? There will be a signal change. And this is, in your Chapman, this concept actually is mentioned in masticator space lesions, motor denervation, cranial nerve 8. So this is, acute, subacute, chronic. But basically, the same concept occurs in tongue. So initially, in the first month, there will be increased signal on stir and enhancement on post-contrast. Then in subacute, it will change. And the definition of subacute is 12 months to 20 months. And then in chronic, there will be fatty change. So I just wanted to highlight this. I have shown you this case before, and it has come in the exam, by the way, this tongue, denervation. And it can be shown to you on a CT scan with fatty infiltration. And the same concept occurs in other parts of muscles also. So this is just a revision. And please remember, if abnormal signal of the tongue is there, the next question will be, what will you do? And you will say that I want to see whole of the neck till base of skull, because the lesion might be sitting at, let's say, the jugular foramen, where it is infiltrating the hypoglossal nerve. And in this particular case, there was a glomus jugulotympanicum, which was causing this. So this was a revision. And this is sometimes what happens. Look at this case, which was referred to us that there is a question mark hemangioma of the tongue. But if you look carefully, this is a T1 bitted sequence, and you can see fatty infiltration on this side. And on this T1, there is fatty infiltration. In this particular case, on the stir, there is slight bit of high signal, and there is a bit of enhancement. So this might be subacute type of motor denervation. And on the other hand, you can see cases like this in which there is complete, fatty infiltration. Last case of the day. This is the last case for today. Look at this,
Yes, sir.
and look at this as a post-contrast sequence. And,
Yeah,
and of course, there is post-contrast for brain. Over to you.
I'm presented with a CT scan of 24-year-old female who has undergone extraction. I can see that there is a lesion in the left infratemporal fossa, which is causing destruction of the underlying zygomatic bone, and it is extending into the left subcutaneous tissue as well. I can also see that on CT brain, there is an extradural connection just adjacent to the left temporal bone with underlying enhancement, so likely representing the there are certain hyperdense areas in within it as well, within the soft tissue. So likely representing the an infectious process which is extending into the brain as well, resulting in empyema, subdural empyema, along with.
So which space is involved? Space-wise.
It is extending into middle cranial fossa, and it's in the neck. It is in infratemporal fossa.
I want to hear the space.
It's in the masticator space.
Excellent. So if you see here, in this case, what has happened is that the patient, of course, had a dental extraction. So there is a plug sitting there. It is not a tooth. And it developed some infection. And when we gave contrast, there is enhancement. So there is an inflammatory phlegmon. The epicenter is along this is the mandibular condyle, etc. Part of it is abscess, part of it is phlegmon. And then it goes all the way up here. You remember masticator space goes all the way to the base of skull to the temporalis muscle here. And from there, the infection has gone in. So there is a subdural empyema here. So this is the masticator space. And we know that it goes and touches there. And you see, this is that muscle which is involved. And we know that it can go to the base of skull. So that was the idea of this masticator space abscess. So sorry, today I think we overshot by about half an hour. In any case, this is finished. Next time we are going to do the neck. This will be the last session, neck. And in neck, suprahyoid neck and infrahyoid neck, I will particularly teach you the larynx, which many people find it very difficult to report. So larynx will be part of the interest next time. Anatomy wise, I think rest of the anatomy is not all that difficult. Main anatomy is of larynx. So next session will conclude this course.